So our next speaker will be Dr. Jason Vaught, and I'm very excited by his presentation. Jason is an assistant professor at Johns Hopkins. He's also the Robert E. Meyerhoff Professor, and is in the Division of Maternal Fetal Medicine in the Department of Gynecology and Obstetrics, as well as surgical critical care in the Department of Surgery. In addition to these titles, Jason is an active clinician and a researcher in Dr. Brodsky's lab at Hopkins and has been doing some very elegant work on defining genetic mutations in women with preeclampsia and the HELLP syndrome. And I read Jason's paper early on when we were first thinking about this topic, and it was really Jason's data that motivated me to suggest this as a topic for today's symposia. So it was really exciting when Jason accepted the offer to present his work today, and I invite him to the podium. Thank you, Jason.
So again, my name is Jason Vaught, and thank you so much to the Foundation of Women and Girls with Blood Disorders for inviting me to give a talk on something that I'm incredibly passionate about. So first, I want to start off with a background and a story. When I was an intern in 2007 at Emory University in gynecology and obstetrics, I remember being in the labor lounge, which is where we do our morning rounds, and having a patient with HELLP syndrome. And my attending looked at me and he said, "Jason, what is the pathophysiology of HELLP syndrome?" And I said exactly this in 2007. And I said it with a lot of confidence. More confidence than probably an intern should have. But I said it's the most severe variant of preeclampsia. It's an endothelial dysfunction. It starts with abnormal placentation, and it affects 0.1 to 0.2% of all pregnancies. And HELLP syndrome stands for hemolysis, elevated liver enzymes, and low platelets. And now, as I have spent most of my academic career studying HELLP syndrome and preeclampsia, I don't know if that's necessarily the case or if it's true. And I hope that when we go through the presentation, you'll kind of see kind of my side of complement upregulation or dysregulation in HELLP syndrome. You can't talk about HELLP syndrome, obviously, without talking about preeclampsia. It is a disease of hypertension with end organ damage, with or without proteinuria. And the end organ damage can be anything from headaches and convulsive seizures to pulmonary edema, elevated liver enzymes, hemolysis, acute kidney injury and proteinuria, thrombocytopenia, or GI symptomatology. A lot of women will complain of epigastric pain or right upper quadrant pain. So again, it's kind of this broad, overreaching diagnosis, where HELLP syndrome affects 0.1 to 0.2% of all U.S. pregnancies. Preeclampsia affects about 5 to 8% of U.S. pregnancies and affects 6.6 million women worldwide. It's responsible of 18% of maternal deaths in the U.S., and it's responsible of 15% of premature births in the U.S. as well. And it is the leading cause of iatrogenic preterm birth in industrialized countries. So us, Europe, like that's the number one reason why doctors are putting women into labor. Going further into HELLP syndrome, when I said that answer as an intern, I kind of thought to myself, well, HELLP syndrome's been around forever. They've always known about HELLP syndrome, and it's probably been discovered since the 1800s, but in fact, HELLP syndrome is the same age as me. It was actually discovered by Louis Weinstein in 1982, and he was actually a maternal fetal medicine fellow at the University of Arizona. His story with HELLP syndrome started with a maternal death after a delivery of a woman who had hemolysis, elevated liver enzymes, and thrombocytopenia, and he and his mentors were actually quite perplexed. So he published a case series of 29 women over the next 30 months of the remainder of his fellowship, and what he found was that many of the patients had mild hypertension. So not the severe range high blood pressures that we're used to seeing with severe preeclampsia. They had these non-specific, kind of almost viral complaints, and some had proteinuria and some did not. Again, the phenotype was what the name says, and all of the women pretty much got better 48 to 72 hours after delivery or post-reversal of the trigger. And he created the acronym HELP because it went well and it kind of told the practitioner that the woman needs help or she needs delivery in her future care. But aside from all the background of HELLP syndrome, it's actually been compared to a lot of complement diseases, namely APS, TTP, lupus, and atypical hemolytic uremic syndrome has been coined the term the great imitator. Here are the HELLP syndrome criteria. There are the Tennessee criteria, the Mississippi criteria, and then there's this thing called partial HELP, which has a little bit of contingency. I'm from Memphis, Tennessee. The University of Tennessee, Memphis is in Memphis. The University of Mississippi Medical School is in Jackson. They're an hour away. I don't know why they couldn't combine and have one criteria, but they decided that they wanted to have separate criteria. As you can see, it's pretty much kind of what we all kind of know: elevated LDHs, increased T-billies, low platelets, AST greater than twice normal of the assay at your hospital. When we talk about aHUS, which I know they'll go into later, it's a disease, again, of hemolysis, thrombocytopenia, renal impairment, ultrarenal status, and liver injury. And it's a disease that looks very similar to HELLP syndrome, just more on the more severe spectrum. It is a dysregulation of the alternative pathway of complement, or the APC. And there is this two-hit pathophysiology that's been hypothesized. One, you need a germline mutation in the complement gene to predispose to disease, and then you need a trigger. So that trigger can be anything from infection or sepsis, cancer, being exposed to a new medication, an underlying autoimmune disorder, and then, of course, pregnancy. The treatment is complement inhibition. When we talk about aHUS and pregnancy, again, it affects 20% of women who are diagnosed with aHUS are diagnosed peripartum. 60% are diagnosed within the first pregnancy. 50% require dialysis. And again, it's really difficult to diagnose from preeclampsia from just really bad HELLP syndrome. Difficult to diagnose from just really bad HELLP syndrome. And other diseases such as TTP and even underlying renal diseases that can come to fruition because of the pregnancy. And again, the pitfalls of aHUS and pregnancy or pregnancy-associated aHUS is that there really is a lack of knowledge among obstetric practitioners. And so number one, it can have iatrogenic early delivery that's not needed necessarily, and it's a delay in the proper treatment. So as our previous presenter said, complement does increase in pregnancy, and this is not a bad thing. It's actually needed. Both the mother and the fetus need to be protected against microbes, abnormal ischemia of the placenta, and so forth. However, we think that women with HELLP syndrome have an overactivation of this complement system, similar to aHUS, but maybe not as severe. So that kind of led me to our first hypothesis, that HELLP syndrome is a variant of aHUS. So they look alike. Research has implicated the APC upregulation in HELLP syndrome. APC-associated mutations have been shown in preeclampsia, and there actually is a case report where they used eculizumab or anti-C5 monoclonal antibody therapy in a patient with HELLP syndrome, and she had improvement in lab abnormalities within 72 hours and a latency of pregnancy of 2 weeks. This is kind of where our research steps in at Johns Hopkins University. So there's this test called the modified Ham assay, and it's originally used to distinguish aHUS from other complementopathies such as TTP and Shiga-toxin HUS. So basically what you do is you take these apoptotic or these like super cells, but you take away GPI or glycophosphatidylcholine, which contains CD55 and 59. When you place these cells in a complement-mediated serum, such as aHUS or HELLP, the cells die, they don't proliferate in the dye solution while they're being incubated, and the well appears light. When you take these cells and put them in healthy serum, like normal pregnant serum or heat-inactivated serum, the cells continue to proliferate during incubation period in the dye. They have mitochondria, and they take up the dye, so the well appears darker. When you take your heat-inactivated versus your participant sample, you take the difference of the colorimetrics of the wells, and that difference in percentage is your cell killing. And we kind of found that greater than 21% or 20.5% is indicative of an increase in the APC. When we looked at patients with HELLP syndrome, we certainly found that a lot of women that had complete HELLP syndrome, shown as C-HELLP, and atypical or partial HELLP, shown as aHELP, do have an increase in non-viable cells or increase in cell death when we use the modified Ham assay. And it was certainly more when compared to healthy pregnant controls and healthy non-pregnant controls. So in that last slide, we kind of showed that there possibly is, or there is, an upregulation of the APC in HELLP syndrome. But what about the gene variants, or what about the germline mutations that we see in aHUS? Would that be similar in women with HELLP syndrome? There have been other studies that have looked at this. Two of the notable studies I have on the screen. There was a study that looked at 33 women that had APC gene mutations in HELLP syndrome, and they found 4 of 11 women that had gene mutations with HELLP syndrome. We decided to create our own cohort where we recruited 13 patients with HELLP syndrome, 14 patients with partial HELLP syndrome, 18 patients with atypical aHUS, and then we had a control cohort of 19 women with healthy pregnancies at term, and then 8 patients with TTP, which we would have expected to not have germline mutations of the APC. Our hypothesis was that women that have HELLP syndrome will also have germline mutations at the 40 to 50% mark that is shown in aHUS. This was a gene panel that we used. We looked at an amplicon coverage of 98%, and we used a sequence used by Illumina MiSeq. We really focused on germline mutations or heterozygosity, so that means that we looked at a variant allele frequency of 40 to 60%. We also wanted a depth of at least 20 times, and we looked at a minor allele frequency of less than 0.1 or 1% or less than 1% of the population, showing that these are rare variants. Also, we looked at non-synonymous coding regions of these variants, meaning that we wanted to look at germline mutations that actually changed proteins and that weren't just synonymous coding variants that really didn't mean anything. Here's our data from this research project, or from this research, and we found that women with HELLP syndrome, we recruited 13, but only 11 agreed for gene testing, and we found that 5 out of the 11 had germline mutations of the APC. This was a trend for women with just healthy pregnant controls, or HPC, but when we grouped our control cohort against HELLP syndrome, we found that there was a statistically significant difference. And then when we looked at HELLP syndrome versus aHUS, we found that it was not different, which is also part of our hypothesis or thesis, kind of leading to the fact that women that have germline mutations, women with HELLP syndrome, in fact, do have germline mutations similar to that of aHUS. Going forward, this is just a schematic looking at the mutations in HELLP syndrome. I want you to focus on the red dots. The red dots are women that have HELLP syndrome. And as you can see that there is a deleted homozygous mutation in CFHR1. There's also mutations in CFHR3 and CFHR5, and even a mutation in C3, kind of showing that these are similar mutations that are found in aHUS or with black dots. The other dots show partial HELLP and with pregnant controls, and we did have 2 pregnant controls that had germline mutations that went on to have healthy pregnancies. When we further looked at the demographics or even the adverse outcomes of women with HELLP syndrome, we found that 7 out of 13 had severe adverse maternal outcome, so 54% of these women. So they required blood product transfusion, they had eclamptic seizures, ICU admission, one required CRRT or hemodialysis, and even outpatient hemodialysis up to 6 months, and mechanical ventilation. In the partial HELLP cohort, we did have 1 out of the 14 that had an eclamptic seizure, just kind of owing to the fact that the cohort that we had were definitely women that were on, even for HELLP syndrome being a severe form of disease of pregnancy, these were still even more severe. And I think that's something that we can all see when you're at academic centers and transfer centers. When looking at fetal adverse events, there were actually 3 terminations, secondary to the fact that the fetus was not viable at the time of diagnosis of HELLP syndrome, or the fetus did not have a reassuring status, and survivability was low or nil. There were 4 infants that had fetal growth restriction, but then go on to be healthy neonates. Out of the partial HELLP group, there were no terminations, but 4 had fetal growth restriction. So not only having sick moms, but also very sick neonates and sick babies. So what do we do about this? HELLP syndrome looks the same, looks like aHUS. It has a similar pathophysiology, and it has germline mutations. So for us, that means that we would like to propose an open-label clinical trial with women at HELLP syndrome at less than 28 weeks. The primary objective would be to look to see if there's an improvement in maternal outcome by lab improvement and decrease in severe maternal morbidity, which would be shown by ICU admission, renal failure, mechanical ventilation, et cetera. But also, and even as important, would there be a latency of pregnancy for at least 7 days? Now, many of you say 1 week is not a long time. This conference is 1 week, your vacation is 1 week. 7 days is not that long, but in the neonatal literature, 26 weeks versus 27 weeks is a big difference. Every day kind of matters for these neonates, so even prolonging it to get beta-methysome complete or get fetal lung maturity, or to even get an extra week has significant health benefits for these neonates. This is, again, a schematic from the American College of Obstetrics and Gynecology. And it just kind of points out that when a woman with preeclampsia goes into HELLP syndrome or is diagnosed with HELLP syndrome or even partial HELLP syndrome, delivery is indicated after getting betamethasone for fetal lung maturity if that woman is preterm. And again, if you're 33 weeks or 32 weeks or even 30 weeks in a great NICU, it's not the end of the world. Your baby will probably be fine. But when you're 24 weeks, when you're 25 weeks, when you're less than 24 weeks and you have to have a termination, that can be pretty heartbreaking. It's my hope that if this trial does continue, that the maternal implications would be decrease in maternal blood transfusions, decrease in severe hypertension and need for antihypertensive therapy, and decrease other severe maternal morbidity such as ICU admission and renal injury or renal failure. Obviously, the fetal implications would be decrease in extreme prematurity or less than 28 weeks, and decrease in NICU stay. Focusing on prematurity alone, preeclampsia and HELLP, there are 400,000 premature deliveries a year. 15 to 20% will be secondary to a hypertensive disorder of pregnancy. And this has a $26 billion yearly societal cost. Each neonate averages about $70,000 per neonate with a 1-year span time in the NICU. And obviously, the earlier the neonate or the earlier the delivery, the more the cost. And then taking away all the financial implications, the emotional cost of the parents of having a neonate in the NICU or having an early preterm neonate also factor in. So in conclusion, the prevalence of complement mutation is similar in both HELLP syndrome and aHUS. HELLP syndrome is mediated by complement dysregulation in a majority of cases. The treatment for HELLP syndrome is delivery, where aHUS is complement inhibition, but a subset of women with HELLP syndrome and their neonates may benefit from treatment with complement inhibition. And so the overarching question is, should we be treating these women?
When you come to the microphone, can you say your name and where you're from?
I'm Avi Akub. I'm a hematologist at the University of Kansas. And a lot of those syndromes have been in the history of medicine for decades. Do you see a future where we're going to revise the diagnoses? So if we get a patient with HELLP syndrome, if the OB is seeing them, they're going to call them HELLP. The hematologist is going to call them atypical HUS. Sure. It's really macroangiopathic hemolysis and complement activation. Are they really that different? And are there a lot of misdiagnoses? The clinical criteria is so loose.
Yes.
It is really not that specific. The science is not precise. So is there a HELLP syndrome? Are they not all complement-mediated atypical HUSs?
That's a very great question, and it's certainly something that I struggle with. I'll take it in separate parts. So I guess let's talk about the criteria. You're right, the criteria are quite loose. The criteria for even preeclampsia is very broad. Part of that is because you want to capture women to take care of them and not send someone home because you're like, oh, well, I don't think it's HELLP syndrome. I don't think it's preeclampsia. So there is benefit to that. But the pitfall to that is that you're right. There are a lot of misdiagnoses. And the criteria itself are more focused on what we see or clinical manifestation and maybe not as much on the pathophysiology behind it. Hopefully there will be a push to have diagnoses based on pathophysiology, but I think that that's something that's, as it took decades for us to get to this point, it'll probably take a couple of decades to do that. I do think that a large subset of women that have HELLP syndrome, there is a complement mediation. I think that that's a good thing because that means that for some of these women, we can actually do something, we can treat them. But I agree, the criteria are quite loose. It's really based on clinical manifestations and not necessarily on pathophysiology of the actual disease, of the underlying disease.
And really the practice has been so arbitrary because if you have a physician who's enthusiastic about the science of complements, they will manage patients very differently based on physicians who don't believe in it, although it's the same patient. And we have this agreement all the time, a nephrologist, an obstetrician, and a hematologist, and having a conference about if this woman who is 38 weeks or got ill right postpartum and which one is it that she has. And,
right.
Again, it's really and I hope it's not decades.
I hope it's not.
Because the science is advancing so fast.
Rapidly.
I hope it's not going to take us decades to re-refine, reclassify these diseases.
Well, I don't think it'll take decades for it to for people to do it, but like with any reclassification, there'll probably be a little bit of pushback. But I agree with you that I think that the science should move it forward and that we should think about reclassifying the disease is based on the pathophysiology behind it and not just what we see because they look so similar. And those arguments happen all in every academic center between nephrologists, hematologists, and OB when we have patients like this.
All right, thank you very much.
Thank you.
Rock from Ottawa. In TTP, the elevation of the LDH is due to the isotope 5. Now, do you know if it's the same thing in HELLP syndrome? In other words, it's muscle injury rather than red cell damage. And if it is indeed muscle injury, why no fever?
Why no fever? So with HELLP syndrome, I don't think the LDH is necessarily due to muscle damage per se.
In TTP, it's well documented that the majority of the LDH is coming from the 5th isotope rather than the 1st.
Right, and I agree with that statement, but I think for HELLP syndrome, I think the pathophysiology may be different, which may explain why there is no fever. I mean, like in HELLP syndrome, there is documented schistocytes and things of that nature, fragmented red cells, to kind of lead to the fact that there probably is red cell destruction. Originally, for hemolysis and HELLP syndrome, it was thought to be more secondary to shearing or endothelial dysfunction, but now I do think it's more complement-mediated. But I think that might be why there's no fever in HELLP syndrome. And also, too, I think I would have to look at the literature to see if anyone has ever looked at CKs in women with HELLP syndrome for muscle injury, but I would assume that it would be quite low. It would not be something where you would be concerned for rhabdomyolysis or something like that. Thank you.
Raul Mena, Burbank Hematology. Mm-hmm. 2 questions regarding your study. By the way, wonderful presentation.
Thank you.
In the women with HELLP syndrome that had fetal demise,
yes,
did you check the children for APC mutations? The kids that died.
So in our IRB, we did not have that in our protocol. Are you saying that did we do gene testing, like genetics, just
to see if the fetal demise was also related to complement activation in the fetus?
We did not, but in our future IRBs for future studies, we are going to add in getting fetal blood sampling or if there is a fetal demise fetal tissue.
Second question is, if we have women with either HELLP syndrome or atypical aHUS, should we be testing them all for APC and their progeny for future pregnancy counseling?
I'm going to say yes, because when you have a woman that has delivered a 25-week pregnancy with her first baby, and then she wants to get pregnant again, what do you tell them? So I personally, I would love to be the one to create the data that says that we should start doing that and to make it a guideline. Or I hope someone in here does. So yeah.
In terms of healthcare costs,
yeah.
Fetal demise, time in neonatal intensive care units, yeah.
Yeah, I think if you did a cost-effective analysis of how much it would cost to give anti-C5 monoclonal antibody for a woman for 2, 3, 4 weeks versus a NICU admission of a 24-weeker, I think that versus a 28-weeker, I think the cost would. I'm not a cost-effective analysis like guru, but I think the cost would probably level out.
Thank you.
And the long-term consequences of having a severely preterm neonate, yeah.
For the sake of time, this will be the last question.
Sure. My name is Carolina. I actually work with Alexion's Medical Affairs.
Excellent.
Question for you. For the presentation of the women in that cohort, was it with their first pregnancy? Because we know that, for example, with atypical aHUS that's triggered by pregnancy, sometimes it occurs with the second or third pregnancy.
Sure.
So there's a different threshold, if you will, and we still don't know what the threshold is. I think it's different for every woman. But with, in regards to this particular study that you presented, was it with their first pregnancy that?
About 60% of women, it was their first. They were nulliparous, so it was their first pregnancy, first-time pregnancy.
Okay, and then the second part to that question is when ECU was used for these women, what about the treatment plan, or is the dosing per the package insert where it's for the atypical aHUS?
So we have not yet. I mean, this is something that I think I propose that should be done. We have not started a clinical trial in women with aHUS or with HELLP syndrome, but if we were, which I think it hopefully will be in the works, we would use the package insert of the 900 milligrams IV Q weekly. We would use the induction for 4 weeks.
Gotcha.
So 900 weekly times 4.
Okay. Do you foresee then in like this utopian world where the ACOG, guidelines will mention, complement-mediated pregnancy-related disorders? Because right now there really isn't. So what happens with MFMs is when they go and and I guess bring in the hematologist. The pathophysiology has already gone on for too long. So.
Well, yeah, and I think that's definitely for future discussion. And I think as women change, as we have more women that have complement diseases that are living longer, women that have cardiac defects that are living longer, they're going to become pregnant. So the society will have to change with the women that we're taking care of.